Hi, good morning, and welcome to Grand Rounds on this beautiful spring day. We're really delighted to have you all here. We have this year been trying to separate some of our Grand Rounds to make sure we're giving opportunity for colleagues in other departments to come meet with us and share their expertise, all in the interest of us getting to know each other and for our patients to have the benefit of their expertise as we move them through our care. We're also doing that within the department, and just to give you a heads up, there was a save the date that went out recently about a mixer that we're calling it, that we're doing sometime in May. I forget the exact date, but that's another opportunity for us because we're so disparate, we're so separate from each other in terms of space and time, that we'll all come together within the department and just spend some time highlighting our new faculty and also just getting to know each other a little bit. Over time, we'll also use that as another opportunity to invite members from other departments to come in and meet with us and for us to get to know them. So in that spirit, we're really delighted to have Deepa Magge here with us today. She received a bachelor's degree from Boston University and was in an accelerated bachelor's MD program. Her bachelor's was in the medical sciences and also psychology, and then she completed her MD also at Boston University, and then went west to Pittsburgh to complete her residency in general surgery, and then did her fellowship around issues that she's going to be talking to us about today, the surgical care of patients with serious oncologic disorders. Dr. Magge really has had a remarkable start to her career, already has over 20 publications, and is working very closely with my colleague Dan LeBeau in developing our oncology services at both hospitals with a lot of focus around GI malignancies and how we can optimally care for those patients. Dr. Magge, it's really a pleasure to have you with us today, and welcome.
Thank you so much for allowing me to speak today. I really appreciate the invitation. I'm going to be talking today a little bit about a particular interest of mine, which is peritoneal carcinomatosis. I did my training at University of Pittsburgh, which is a big Hypec center. I think there's a lot of misconceptions about peritoneal disease and what we can and can't do for it. And I was hoping to clarify some of those misconceptions today for you guys, and also to give you a little bit of an idea of when surgical management of advanced peritoneal disease is appropriate and when we kind of go the palliative route. So this is a little bit of an esoteric topic, but it is becoming more and more common in the management of our patients. And I know I get a lot of consults for advanced cancers, and I'm hoping today's talk will help you guys understand where I'm coming from in the management of some of these patients. And there is a few case scenarios at the end of the talk, so I'm going to pick on a few of the residents. I don't know who's a resident. I'm assuming they're in the back, but I'll pick on a few just to help see if they actually learned something from today's talk. So the title of today's talk is Locoregional Therapy for Peritoneal Carcinomatosis, to be aggressive or not to be. So I have nothing to disclose. So I'm going to begin with talking a little bit about the background of peritoneal disease, and then about cytoreductive surgery and Hipec. I'm going to talk about the preoperative planning that's involved in some of these pretty big cases. I'm going to talk a little bit about the procedure and the agents that we use. I'm not going to go too much into detail about this, given you won't be performing these surgeries, but I wanted to give you a little bit of background in regards to how we actually do these surgeries. I'll talk about our outcomes here at Mount Sinai, as well as national outcomes. And at the end, as I mentioned before, I'll be talking about some case scenarios. So a little bit about the background of peritoneal disease. So peritoneal dissemination from GI and gynecologic cancers is quite common. Appendiceal cancers are actually the most common, resulting in pseudomyxoma peritonei, which is essentially peritoneal implants resulting from mucinous appendiceal neoplasms. They range all the way from benign processes, so you can have benign mucoceles of the appendix that result in peritoneal implants, all the way to appendiceal cancers, which can be quite aggressive, and they also result in what we call pseudomyxoma peritonei. But the treatment of these range in terms of surgical management all the way to medical management. We also see peritoneal dissemination in colorectal malignancies, as well as gastric and ovarian malignancies. Primary peritoneal malignancies are less common, though we do see it. Peritoneal mesothelioma is one of the most common primary peritoneal malignancies that we do see. We have a big Hipec center here, so we do see it quite commonly, but universally it is an uncommon phenomenon. We see recurrence with some of these malignancies, sometimes confined to the peritoneum. So for colorectal cancers, 10 to 35% of patients who initially present with a resectable lesion will recur with peritoneal disease alone, as well as 50% of gastric cancers will present with metachronous peritoneal disease, meaning they might undergo their segmental gastrectomy, and then somewhere down the line, 3 to 5 years later, they present with peritoneal dissemination. The morbidity and mortality that's associated with the peritoneal dissemination is secondary to this locoregional spread process. It's essentially a pushing phenomenon of tumor on bowel, on colon, on stomach, resulting typically in obstructive type processes. That's really where the morbidity comes in. And I'm sure you've seen patients that have come through the ED that you're consulted on for small bowel obstructions, etc., that have significant disseminated disease. The obstructions are resulting from this pushing phenomenon of tumor implants, not necessarily invasion of the tumor into the bowel. So we believe in this redistribution phenomenon. We believe the peritoneal cavity has this clockwise directional flow of peritoneal fluid. In the OR, what we often see with these patients with peritoneal dissemination is patients with a lot of pelvic disease, pelvic implants, as well as subphrenic or subdiaphragmatic implants. And we believe that's because there's this clockwise gravitational pooling of the peritoneal fluid in the abdomen, and it results in this certain type of spread of the disease. We also see a lot of disease in the omentum. You'll see, we call it caking of the omentum. It's because we believe the omentum has this phagocytic activity, and it results in this large tumor implant within the omentum. Sometimes the greatest morbidity of these cancers is actually because the omentum becomes this large plaque, and it pushes down on the bowel, resulting in bowel obstructions. So sometimes the procedure that we do in the OR is just an omentectomy, and that alleviates a lot of the morbidity of these patients. We believe that peritoneal carcinomatosis can be treated as a local regional disease process. You know, about 20, 30 years ago, when you had peritoneal carcinomatosis, regardless of the primary disease, it was considered a death sentence. Patients were told they had 6 months to live. There weren't many options for them. But based on the primary pathology and the biology of the disease, oftentimes cytoreductive surgery and Hipec can actually become a curative treatment. So when I say the pathology, like I mentioned before, appendiceal neoplasms range all the way from benign processes to malignant processes. And then we have colorectal cancer, gastric cancer, ovarian cancer. So we rate these primary pathologies from benign to super aggressive tumors. For the benign processes, cytoreductive surgery and Hipec is a wonderful treatment. We see really low recurrence rates. Patients can have 10 years disease-free survival. But then when you get to the really aggressive malignancies like gastric cancer, the benefit of cytoreductive surgery and Hipec probably is not there unless they have really minimal disease and they have a long disease-free interval. The surgical role for treatment of these diseases has actually become less palliative and now leaning towards more of a curative. So the rationale for Hipec, why do we do this? So Hipec is hyperthermic intraperitoneal chemotherapy. So we know that oftentimes the systemic chemotherapy is not very effective for patients with peritoneal disease. And that's because there's poor blood supply to the peritoneal surface. There's low penetration of the systemic chemotherapy into these tumor nodules. To be able to treat these tumor nodules with systemic chemotherapy alone, we need to give really high doses of systemic chemotherapy, which patients don't often tolerate. There is what we call this plasma peritoneal barrier. We believe that the peritoneum actually limits the systemic drug diffusion into the peritoneal space. So, like I mentioned before, to get the systemic drugs to actually overcome this barrier, we have to give it at really high doses, which patients often don't tolerate, secondary to morbidity from these chemotherapeutic agents. So, Hipec, which I mentioned before, is hyperthermic intraperitoneal chemotherapy, is essentially local chemotherapy that we put into the abdomen. It allows for delivery of high local concentrations of agents with reduced systemic toxicity. There is some minimal systemic toxicity associated with Hipec because there is some systemic absorption of the chemotherapeutic agent, but it is quite minimal. We believe that by maximally removing all of the gross disease that we see, and then we immediately follow that gross removal by introducing this hyperthermic chemotherapy into the abdomen, we expose the peritoneal surfaces to the chemotherapy, that's the best treatment for the peritoneal disease. So how do we decide which patients can have the surgery and which patients are not candidates? So it's all based on A, the biology of the disease, the primary pathology, and B, the quantity of disease, so the tumor burden that we see. We use imaging like CAT scan, as well as diagnostic laparoscopy that we perform preoperatively to determine if a patient is a candidate for this pretty extensive surgery. So we use something called the Peritoneal Cancer Index, which is other known as PCI. And basically, we divide the abdomen into 12 areas. And each area gets a score between 0 to 3 based on the size and the extent of disease in each of these areas. And then we add up those 12 areas and we get a score. So we believe that a score above 15 is associated with higher morbidity. And patients with extensive PCIs typically aren't candidates for the surgery, or if they are, they don't typically do that well. So our whole goal is to perform a complete cytoreduction, meaning we have to remove all of the gross disease. So we give a cytoreductive score between 0 to 3. Our goal is to get a CC score of 0, which is essentially not seeing any gross disease at the end of our resection. It ranges up to 3, which is where we leave disease up to 2.5 centimeters in any of the quadrants. When we get a CC score of 3, we do not perform a perfusion with the chemotherapeutic agent because we believe there's no benefit to the chemotherapeutic agent if you're unable to perform a maximal cytoreduction. So only for CC score of 0 or 1 do we perform the Hipec itself. So the findings that we see on imaging that lead us in one direction or another in terms of whether we're going to be able to perform the surgery or not. When we see segmental bowel obstructions or segmental colonic obstructions, particularly small bowel obstructions, that is portending a higher morbidity and a less likely chance that we're going to be able to complete a complete cytoreduction. Really, the limiting factor in terms of whether we're going to be able to complete a cytoreduction is the bowel involvement. We can remove the entire colon. We just can't remove the entire small bowel. A patient cannot survive without at least 120 centimeters of small bowel in continuity. So if there's significant small bowel involvement, that patient is not going to be a candidate for cytoreductive surgery. We also, if we see a PCI greater than 20, I say 20 here, but in my eyes, a PCI greater than 15 portends a higher morbidity, but a PCI greater than 20 really should not undergo a cytoreductive surgery because the likelihood of having a CC0 is quite low. So cytoreductive surgery is not a new phenomenon. It actually was described for ovarian cancer in the 1930s. It's essentially the removal of macroscopic disease. It not only palliates symptoms, but it can, some say that the cytoreductive surgery itself without the Hypec is actually what improves patients' overall survival and disease-free survival. The Hypec itself, the hyperthermic intraperitoneal chemotherapy, was introduced in the 1980s, so it also is not a new phenomenon. But only in the past decade has it really been implemented in a wide range of pathologies, and there's been more and more clinical trials that have shown the benefit for Hypec. There was one randomized controlled trial that was performed in 2018 for ovarian cancer that showed the use of cytoreductive surgery and Hypec as a benefit in terms of improving overall survival in patients with recurrent ovarian cancer. So the goal of the cytoreductive surgery, as I mentioned before, is to remove all macroscopic disease through peritonectomy and multivisceral resection. The extent of the disease varies in accordance with the cancer volume and the anatomic location. We perform limited peritoneal stripping, and what I mean by that is the abdomen has this parietal peritoneum as well as a visceral peritoneum, and we perform stripping or removal of that peritoneum if it's involved with disease. So the cytoreduction itself can involve all of the above or all of the below resections. The morbidity, obviously, of the morbidity of the operation is higher when you perform a more extensive resection. We always call spleens and gallbladders gimme organs because they're easy to take out and they are not associated with high morbidity when we remove them. But small bowel resections, colon resections, gastrectomies, those are increasing the morbidity of the operation. And the highest morbidity is associated actually with pancreatectomy because there's a high rate of pancreatic leaks associated with this surgery. So the Hypec agents that we use. So there was a study in 19 actually looked at the depth of tissue penetration by various agents and identified a group of cytotoxic drugs that actually penetrate 1 to 3 millimeters into the tissue. So that's why we say the tumor deposits left behind have to be less than 2.5 millimeters in size for the intraperitoneal chemotherapy to actually have some effect. So from what I said before, you have to perform a good cytoreduction prior to using the intraperitoneal chemotherapy because it won't have any effect if you don't. So the drugs that we use have to be large, they have to have high molecular weight, they have to be hydrophilic, and they should be ionized in order to be able to work. So this is a list of the drugs that have been used for Hypec and Epic, which is a totally different treatment, but the most common agent that we use in our institution as well as the institution that I've trained is mitomycin C. It's been shown to have the lowest morbidity and the least nephrotoxic agent. We do use cisplatin as our primary agent for patients with ovarian cancer because patients that are treated with ovarian cancer are typically treated with a platinum-based agent for systemic treatment. So we use that as their Hypec management as well. We don't use doxorubicin here or anywhere that I've seen. There was a study recently that was done in France that looked at, it was a randomized controlled trial for patients with colorectal cancer, and they used oxaliplatin for a 30-minute period, and it wasn't shown to be effective. So we don't use oxaliplatin here. So the Hypec itself, so we deliver the chemotherapy into the peritoneal cavity. We want the temperature to be 40 to 43 degrees in order to work. So how do we do this? We essentially set up a bypass machine. So similar to how we do cardiac bypasses, we do the same thing. We place an inflow cannula into the abdomen, and we place an outflow cannula into the abdomen, and we hook it up to a bypass machine. And the bypass machine essentially increases the heat of the inflow of the chemotherapy to a maximum temperature of 43 degrees. We believe that the best temperature to keep the Hipec at is 42 degrees, because above that we start to see cytotoxicity of normal cells in addition to the cancer cells. So we use a 42-degree outflow temperature as the temperature we want during our Hipec. So we basically do this in a closed phenomenon. So we remove all of the gross disease, we place our inflow and outflow cannulas into the abdomen, we close the abdomen, cannulas to our bypass machine, and then we inject the chemotherapy into the abdomen, and we do a 90-minute perfusion of the chemotherapy into the abdomen. Essentially, we do it this way because if we did it in a delayed manner, meaning we did the surgery up front and then we brought them back at another time and did the Hipec, the patient would develop adhesions, and it would make it very difficult to actually get all of the peritoneal surfaces exposed to the chemotherapy. So we do it immediately after we complete the cytoreduction. So we think that there is a combined effect of the hyperthermia itself of the therapy, as well as the direct cytotoxicity of the chemotherapy itself. So the hyperthermia can have direct cytotoxic effects. So you can obviously, you know that high heat can cause apoptosis. So we believe that the hyperthermia itself is very important in the actual treatment of the disease. The most important thing during the Hipec portion of the case is that there are hemodynamic changes associated with the hyperthermia as well as the chemotherapy. So there always has to be an attending in the room during this period of time, because patients can have hemodynamic fluctuations. So one of us always has to be available or around in case any of these changes occur. So in terms of the literature review showing benefit of this procedure, so in the past there was very little randomized data supporting the use of cytoreductive surgery in Hipec. The majority of the data is retrospective because it's very hard to put patients on trial for this treatment course, because there's a variety of disease processes that we use this treatment for. Like I mentioned before, though, there is new literature coming out, the ovarian cancer literature, the study done in the New England Journal of Medicine showing that there is benefit of cytoreductive surgery in Hipec for patients with recurrent ovarian cancer. And then on the other side of the coin, the French trial showing no benefit of cytoreductive surgery in Hipec for colorectal cancer, but that's in a setting where they used it for 30 minutes in a drug that we don't use. So there is new data that's emerging, but we need more. So the outcomes for cytoreductive surgery in Hipec. So it is associated with a higher morbidity. There is a mortality rate associated with it. Why is there morbidity? Obviously, we're doing extensive surgery, so this can involve bowel resections, pancreas resections, etc. But also, we're introducing hot chemotherapy into the abdomen, which could potentially affect our anastomoses, or where we connect our bowel together. So we can see anything from wound infections, which are pretty low morbidity, all the way to anastomotic dehiscences or disconnections of our connections that we make in the operating room. We do see some systemic toxicity of the chemotherapy, especially when we use cisplatin. We can see some renal toxicity, but when we use cisplatin, we use it at we dose it based on weight, and then we give the patient significant amounts of IV fluids to prevent the renal toxicity. But we do see some renal failure in patients with cisplatin. It's a lot lower with mitomycin C. The mortality that we see is associated with anastomotic dehiscences, sepsis, and respiratory distress. The range, quoted in the literature can be anywhere from 2 to 12%, and it really is based on an institution's experience. So if you're doing, 2 to 3 Hipecs per week versus 1 Hipec in a year, you're going to see very different rates of morbidity and mortality. So the associated factors that are associated with higher rates of morbidity are higher age, a higher PCI. If we do more extensive resections, that's going to be associated with higher morbidity as well, and institutional inexperience. So I'm just going to go into our institutional analysis. One of our residents actually performed an institutional analysis of looking at how our patient outcomes actually changed with experience. So she looked at the first 5 years between 2007 to 2011 as our early cohort, and the Hypecs performed between 2012 and 2017 to look at whether the experience, patient selection, all of those things improved overall outcomes in the later cohort. So this was a single institution retrospective review of a prospectively maintained database. So it included all patients who had cytoreductive surgery and Hipec for peritoneal carcinomatoisis for any primary tumor origin between 2007 and 2017. The only exclusion criteria was patients with extra-abdominal metastases. So we broke up our cohorts into 2 cohorts. One was the early group, which was the 2007 to 2011 group, and then the late cohort, which was the 2012 to 2017 group. So the operative technique consisted of performing a diagnostic laparoscopy in order to get a preoperative PCI on our patients. Then all patients, after they underwent cytoreductive surgery and Hipec, had a CC score or cytoreductive score assigned to them. As I mentioned before, we do all of our Hipecs in a closed technique. This is just a picture of the closed abdomen during the perfusion. So there's an inflow cannula at the top and an outflow cannula from the bottom. And those are temperature probes. The white strings that you see there, those are temperature probes that allow us to monitor the patient's inflow and outflow temperature during the Hipec itself. So we had 388 patients who underwent cytoreductive surgery and Hipecs during that 10-year period. The early cohort had 157 patients, and then our late cohort had 231 patients. So the primary tumor origin ranged all the way from colorectal to ovarian, included some mesothelioma, had some upper GI, including some gastric. The significance of the distribution wasn't significant, but the majority of our patients actually had CRS Hipec for colorectal tumors. So our intraoperative outcome, as you can see here, the blue is the early period and the pink is the late period. There was a significantly higher estimated blood loss found in our early cohort compared to our late cohort. Our operative time also was significantly higher in our early cohort compared to our late cohort. Our ICU stay and admission was higher in our early cohort compared to our late cohort, and our median length of hospital stay was also significantly higher in our early cohort compared to our late cohort. So in terms of morbidity and mortality, there was no significant difference in terms of the Clavien-3 for morbidity in 30-day period. And there was no significant difference in our 30-day mortality either in, between the early and late cohorts. But when we look at overall survival, there was a higher overall survival in our late cohort. It was actually over 66 months compared to 31 months in our early cohort. The progression-free survival was a little bit longer in our late cohort. It wasn't really much higher. It was 13 months compared to 11 months, but this was also significant. So in terms of the summary of the results, the late cohort had a lower PCI in terms of the patient selection. We had fewer organ resections, lower EBL, shorter operative times, and more aborted procedure in our later cohort. In terms of our perioperative outcomes, we had fewer ICU admissions, shorter length of stay in our later cohort, and we had a longer overall survival and longer progression-free survival in our late cohort as well. So what does that mean? What were we doing differently in our early cohort compared to our late cohort? We were selecting better. So a lot of data has come out in terms of who to perform these operations on, and as I mentioned to you before, it's all based on the primary pathology as well as the extent of disease. So we are very cognizant of how extensive a patient's disease is before we enter the operating room. So patients with primary appendiceal neoplasms that are benign but have significant disease, we're very aggressive towards them because they don't tend to respond well to chemotherapy. But when we have patients with gastric cancer that present with peritoneal disease, but we typically do not offer them a cytoreductive surgery, despite some of our outcomes. So I'm going to go into some scenarios. Do we have any residents in the room that could maybe be a volunteer for one or two of them? What's your name?
I'm Gaurav.
Hi, Gaurav. Do you mind being the volunteer for the first scenario?
Sure.
I won't be mean, I promise, okay? So we have a 35-year-old man who presents to clinic with significant abdominal distension and early satiety. So this is a picture of his CT scan. So as you can see here, he has a lot of this fluid. It looks different than simple ascites because you can actually see this rim enhancement of this fluid. In the picture on the left, you can actually see some omental caking. So that's what we call omental caking. I'll point it out to you. This is all omental caking there. His CEA was 75. He has a normal CA 125 and a normal CA 199. How do you think we should approach this patient?
So, he has he's young, has an elevated CEA.
Mm-hmm.
So it's probably something from the bowel, either like small bowel or colorectal cancer.
Okay.
So I would try to get a cytology from the fluid by ultrasound guided para and seeing if that helps. Then while I'm doing the routine diagnostic workup, I would also do a colonoscopy and an EGD to see if there is if I can find a foci anywhere, treatment might depend upon whether we find this or not. And I do have some follow-up questions about the imaging. Was a CT angio done for seeing the position of the vessels and everything?
So we typically do not perform, we do CT with IV contrast, but we don't do CT angios because, like I mentioned before, peritoneal disease typically doesn't cause invasion into the tumors like we see, invasion into the vessels like we see with pancreas cancers, where we want to actually see the location of the vessels in accordance with the tumor. For peritoneal dissemination, it doesn't typically invade the vessels, rather it might coat it, and we are typically able to strip it off the vessels. So we don't typically do a CT angio, but we do CT with IV contrast and PO contrast.
Was the CT chest also done?
Yes, correct. Always do a CT chest for staging purposes, correct. So that was perfect. I 100% agree with your approach to this patient. So likely a GI source, correct? It's elevated CEA, has mucinous deposits. This is what we call, we see this rim enhancement of this hypodense fluid on the CT, and we see omental caking. This is really this associated with a colorectal malignancy or appendiceal malignancy. This is what we see. So agree with doing a full diagnostic workup with getting sampling of the fluid. Oftentimes, the fluid itself will not give any cells because it's mucin, and the mucin sometimes is acellular. But at least it'll give us a little bit of information. I agree with doing an EGD and colonoscopy to see if we have a source. The other thing I would perform in this patient is CT chest, like you mentioned, to complete the staging to make sure they don't have metastatic disease in the chest. And then I would perform a diagnostic laparoscopy on this patient. Sometimes a paracentesis or an FNA or an IR-guided biopsy is not adequate. So we'll perform a diagnostic laparoscopy not only to give us a PCI, like I mentioned before, or tell us how much tumor is actually present, but also to get a biopsy and get a little bit more tissue so we can figure out what the source of this is. Now, let's say this was an this came back as an appendiceal neoplasm. Let's say it was a appendiceal mucocele as the primary tumor. What do you think we should do for this patient?
would probably get a cytoreductive surgery. I'm not sure of the evidence for Hipec in like a mucosal kind of tumor. So I think a cytoreductive surgery with follow-up should suffice.
Okay, so I agree with you in terms of not offering systemic chemotherapy first. I would, because if it's a benign process, they don't require chemotherapy and they don't respond to chemotherapy. So I would perform a cytoreductive surgery in Hipec in this patient if the tumor burden was adequate to perform the actual surgery and be able to complete a complete cytoreduction. The Hipec I would perform in a benign case because actually in the really benign appendiceal lesions, that's where Hipec has been shown to improve the progression-free survival or the disease-free interval. So we do cytoreductive surgery and Hipec in this group of patients. But you're exactly right in terms of taking this patient straight to the OR rather than doing chemotherapy up front. So just a little bit about appendiceal neoplasms. They range from low-grade mucinous neoplasms to high-grade appendiceal cancers. Cytoreductive surgery in Hipec is beneficial for low-grade disease because there's a poor response to systemic chemotherapy. The high-grade disease tends to be more responsive to chemotherapy, so we'll start with systemic chemotherapy up front. We'll assess response on imaging, and if they have disease that is debulkable, we'll proceed with surgery. So scenario number 2, Marcelo, can you be the volunteer? Okay, so you have a 64-year-old male with a history of perforated right colon cancer who presents with abdominal distension, nausea, and vomiting. His CT abdomen and pelvis reveals a mental caking. There's little evidence of additional disease. He has a CEA over 300. What do you think we should do for this patient? Oh, yeah. Oh, of course.
Sure. I'll just stop there and if you don't mind repeating my answer so they can. So similar to the other case, so it's middle-aged to elderly gentleman with perforated right colon cancer, symptomatic. We have a mental caking. So we know his diagnosis already. So I think, as Carol was mentioning in the previous case, to complete the staging, probably would do CT chest to make sure that he doesn't have disease in the chest because that would exclude him. And then in the approach, I think this would be a good candidate for a consultation with surgical oncology for a laparoscopy and probably like intraperitoneal chemotherapy.
Okay, so Marcelo said that we would complete the staging workup with the CT chest, and then we'd proceed with a cytoreductive a diagnostic laparoscopy and cytoreductive surgery in Hipec. So I agree with completing the staging workup with CT chest. I would do an EGD and colonoscopy. Just, you never know. You could have a gastric cancer that a patient with HNPCC or something else that could have a gastric cancer, and you're treating it as a metastatic colon cancer. So I would complete an EGD and colonoscopy just to make sure that there's no other disease findings. And then for this patient, I would perform a diagnostic laparoscopy and get a biopsy. Now the question is, should we start with systemic chemotherapy first? And this is where the controversy kind of comes in. So patients with colorectal cancer with limited disease, so the only disease that looks involved here is the omentum, I would still do systemic chemotherapy first, only because for colon cancer, we have to look at the biology of the disease. So by treating them with systemic chemotherapy first for a 3-month period and reassessing whether they progress while on their systemic chemotherapy, we note whether the biology of the disease is more aggressive or if they're going to actually respond to the surgical treatment. Because the last thing we want to do is perform a surgery and then 3 months later, when we repeat their imaging, see diffuse metastatic disease in the liver, in the chest, etc. So by doing chemotherapy up front for colorectal cancer, we get a chance to assess the biology of the disease and also give them a treatment effect, because a lot of times they will respond to the systemic chemotherapy. So for this patient, I would treat up front with some systemic chemotherapy and then proceed with cytoreductive surgery and Hipec. So the indications for for cytoreductive surgery and Hipec in colorectal cancer really is patients with low volume disease, no progression of disease while they're on systemic chemotherapy or limited progression. And then, as I mentioned before, there was one randomized control trial that did show benefit of cytoreductive surgery and Hipec in colorectal cancer. So there is benefit of this treatment process. We just have to treat the appropriate patients. So that's why we do systemic chemotherapy up front. So in the interest of time, I'm just going to, talk about gastric cancer, because I think that's one of the common cancers that we see in an advanced stage. I get consulted on this a lot in hopes that we can actually do something for these patients. And unfortunately, gastric cancer is probably the most aggressive cancer that we see. And cytoreductive surgery and Hipec for this group of patients is often not beneficial. The only patients I will offer this therapy on or for is patients with very limited tumor volume. So PCI less than 5, and after having at least 6 months of chemotherapy with no progression of disease while on chemotherapy. And the reason we make the rules so stringent for this group of patients is because we know that they tend to progress despite their treatment. So I'll give you an example. I recently did a cytoreductive surgery and Hipec on a patient. She is 49 years old. She had very limited disease. She had an ovarian implant. She had a mental caking and some peritoneal disease. And obviously the gastric cancer itself. So she presented when she actually had her gastric tumor in place. So she had 6 months of chemotherapy. She had side effects from her chemotherapy, and there were really no other options for her. She had no progression of disease while on chemotherapy. So I offered her cytoreductive surgery in Hipec, and I did her surgery in August of 2018. And unfortunately, she recurred last month. So, I beat myself up for offering her that therapy, but in this group of patients, there's so limited options that we kind of do whatever we can because we don't have anything else to offer them. So the only patients I really will offer the surgery on are those that can convince me that they are not going to progress within 3 months after their surgery. So very limited for this group of patients. So just in conclusion, carcinomatosis results from a wide range of primary pathology and outcomes. It's very important to have accurate pathology because that will change our management of the disease. The role of aggressive cytoreduction and Hipec is there for the appropriately selected patients, or patients with low-grade processes and low tumor volume. Those are the patients we offer this therapy for. And it's very important that all of these surgeries are done at high-volume centers. As I mentioned before, with experience comes better patient selection, better surgical abilities, and just the overall treatment of the patient postoperatively improves with experience. So that's why Mount Sinai is a Hipec center. So we have a very good experience here. So that's why I actually came here. They recruited me here because of my Pittsburgh experience. And that's why I want to, focus on the importance of doing this in the appropriate patient. So just future directions for Hipec. I think there's a really great need for collaboration. There's a lot of conferences that are offered for this disease process. We have multidisciplinary conferences every month and every 3 months for peritoneal disease alone. Medicine, pathology, radiologists, all are welcome. So if you're interested, and if you're going into medical oncology as a resident and you're interested in coming to these conferences, please let me know. You're more than welcome to join us. But I think the most important thing in the treatment of this disease process is really doing it in a multidisciplinary fashion and choosing the appropriate patient. So I'd just like to say thank you. Thank you so much for allowing me to speak today. I really appreciate it. I hope I clarified a few things about this disease process and who we offer this surgery to. And if you have any questions, please feel free to ask me. And if you have any patients with GI malignancies that you're just unsure what to do with, I'm always here. I'm here at St. Luke's and down at West. I'm always open to seeing any patients that you need help with. So thank you so much. Any questions?
A couple. I'm is it on? Oh, it's on. Is this on? Can you hear me?
I can hear you.
Can you?
Yes.
Okay. Couple of things. One, there's a very common enlarging abdominal mass that never causes obstruction. Maybe not never, but hardly ever. And that's pregnancy. Mm-hmm. So I'm trying to figure out how this then causes, without invasion, obstruction as commonly as it appears from your discussion. That's the first. The second question I really want to ask is also the cost-benefit ratio. So what is the cost of all these procedures, and clearly close follow-up? And how is the patient's experience of this process assessed?
Those are all great questions. So in terms of comparing it to pregnancy, so in these tumor implants, when I say it doesn't cause direct invasion, these are thick implants that are pretty much plastered on the bowel. So it causes obstruction because it essentially results in this fixed state, similar to adhesions that can cause the bowel to twist. A lot of times these plaques actually either compress the bowel or they result the bowel to twist on the tumor implant itself. So it's a little different than this uterus that can move. The tumor implants typically can't move. They're just stuck in one place and can result this fixed point for obstruction to happen. In terms of your second question for the cost benefit, so I don't know the exact numbers for the cost. So the benefit, though, it's all based on who you do this surgery for. So we don't offer it to everyone that walks through our door. We know who it benefits and we know who it doesn't benefit. The tough questions are when you have a patient with gastric cancer and you know there's no other options. What do you do for those patients? And that's where I don't know if the benefits for cytoreductive surgery, Hipec, is there to outrank the morbidity as well as the cost of it. But for patients with benign appendiceal neoplasms that come in with significant disease, we know that these patients really do benefit from the surgery, and the benefit overweighs the cost, because the overall survival for some of these patients can be 10 to 20 years. And the disease-free interval also can be up to 10 to 20 years for these patients. So for those patients, we know it benefits them. So I personally don't look at the cost. I don't know the exact numbers. It's something to ask my boss. But for those patients, we know that it benefits from a clinical perspective. We perform the surgery. In terms of your last question was in regards to how we surveil them. Okay, so after the surgery itself, it depends on the disease process. So for patients with colorectal cancers or for appendiceal cancers, we follow up. We do follow-up CT scans every 3 to 3 years, and then 6 months for the 2 years after that, and then every year after that. For the patients with benign appendiceal neoplasms, we follow them annually with CT scans and tumor markers. For patient experience, we are doing patient surveys. We see them very often, so we actually have very close follow-ups with these patients, so we know how they're doing. It is associated with high morbidity, so there are high readmission rates for these patients, I'm not going to lie, but we know that for the majority of the patients that we offer this surgery to, we feel that they're gaining a benefit from it, and most of the patients are advised about the morbidity and the risks of the operation preoperatively, so they know the risk-benefit ratio before we do that. So the patient experience, it's not, you know, rainbows and butterflies. They oftentimes do have to come back to the hospital for, you know, bowel obstructions or for issues with their labs, things like that. But for the most part, we treat our patients quite well, and they do relatively well.
Thank you for the talk. I just had a question about, you know, how for systemic chemotherapy, there are usually multiple cycles involved. Is there a role of like multiple cycles?
That's a great question. So a patient can undergo multiple Hypecs. We actually published a study that looked at performing multiple Hypecs in patients with recurrent disease. So as of now, we don't have scheduled repeat Hypecs. So we don't do one and then say in a year we're going to do another one. It's more based on recurrence of disease. So if a patient has a cytoreductive surgery Hypec for, let's say, an appendiceal neoplasm, and then 3 years, 4 years down the line, they recur, we will offer them a second cytoreductive surgery in Hypec, but it's based on the quantity of disease. Oftentimes the second and third Hypecs are a lot more difficult because there's a lot more scarring, but we have shown in our institutional analysis that the morbidity is actually not much higher than the initial Hypec itself. So patients tend to do well. But at this current state, there's no role for electively doing multiple Hypecs. All right. Thank you so much. Thanks.